All right, so this is our week 14 review. We're going to be covering chapter 19 and 20. Chapter 19 is about diseases of the skin and eye, and chapter 20 is about diseases of the nervous system. So let's get started with that. These were some of the major concepts from chapter 19. This is my little mini overview of that. The skin and the eye have a similar biota, and so that's the other thing with these chapters. They all start off with what kind of microbiome do we naturally find in those areas. With the skin and eye, the most common microbes that we see on the skin are usually Staphylococcus epidermidis and Propionic bacteria acnes. Those are pretty common things that we would see: P. acnes and S. epidermidis on the skin. Defenses of the skin would be high salt present on the skin, the low pH of the skin, presence of lysozyme, which we see present in tears, which would be part of the eye defenses, as well as in sweat and in saliva, which we would talk about saliva in a different chapter. But getting that idea there. And remember, lysozyme is an enzyme that breaks down peptidoglycan in the walls of bacteria. And of course, keratin, really important factor of the outer layer of the epidermis. What we call the stratum corneum, it basically is like the keratinized layer of skin cells. Um, Keratin, again, being a waterproofing protein, it kind of sticks those skin cells, many of which on the outer layer are actually like dead skin cells, and keeps it basically tries to keep it relatively impervious to microbes from penetrating the intact skin. Yes, so Propionibacterium acnes and Staphylococcus epidermidis. I didn't even realize it was on the slide because I thought I left it out. Alrighty. So some of the illnesses that are associated with this chapter, we have impetigo, which is basically like a sloughing sort of disease of the skin. We have separation of the epidermis cells sloughing off from like the dermis underneath it. And impetigo is that caused by exfoliative toxins produced by the bacteria. Impetigo is usually started by the presence of Streptococcus pyogenes and then often progresses then to Staphylococcus aureus. So we often start with Strep pyogenes and then it is taken over by Staph aureus. And oftentimes the Staph aureus outcompetes the Strep pyogenes in impetigo. All impetigo. Impetigo is very common on the faces and scalps and stuff of little kids. It's pretty contagious, and once we get older, we're a little bit more resistant to it. Again, it's basically driven by exfoliative toxins that are produced by the bacteria. Strep pyogenes is also associated with necrotizing fasciitis. It's easily the most common cause of necrotizing fasciitis. Streptococcus pyogenes is. But there are plenty of other bacteria that can lead to necrotizing fasciitis. So it's not only caused by strep pyogenes, it's just most commonly associated with strep pyogenes. We even had a case in our presentations about necrotizing fasciitis being caused by Streptococcus pneumoniae in my Monday, Wednesday morning class. So that can be caused by other types of bacteria. But most commonly strep pyogenes. When we think of strep throat, we're thinking of it being caused by strep pyogenes, Streptococcus pyogenes. Streptococcus pyogenes is gram-positive cocci bacteria, and it's strepto arrangements. We often have it in chains or pairs. And so those are some pretty interesting characteristics about it. Other diseases associated with Streptococcus pyogenes, of course, would be scarlet fever or rheumatic fever. A lot of times that is progression of the strep throat that we often see. And again, strep throat is a pharyngitis. We'll see it again in chapter 22 when we talk about the respiratory diseases. But if we see expression of scarlet fever, that would be at the skin level. We have rash associated with that. And the rash is basically driven by the erythrogenic toxin produced by Streptococcus pyogenes. And that erythrogenic toxin is coated by a phage that the strep bacteria were infected with. So that is a lysogenic conversion associated with that. If we remember that from chapter 7 about our viruses and how they can impart new genes on our bacteria that way. All right. Staphylococcus obviously is also associated with MRSA. MRSA is a kind of Staph aureus. It is methicillin resistant Staphylococcus aureus. So any species of Staphylococcus aureus that is resistant to methicillin, which is a type of antibiotic, or anything stronger than methicillin, would fall into that MRSA category. And then we would need to do like a Kirby-Bauer assay or something like that to determine what antibiotics would still be effective against this antibiotic resistant strain of Staphylococcus aureus. Not all staph are MRSA. Only ones that are resistant to methicillin would be considered MRSA. Okay. MRSA causes the exact same types of infection that regular staph does. It's just less treatable with antibiotics. So that's the real issue with it. MRSA is also all staph are commonly spread around in hospital environments, but the most difficult to control ones are the ones that are antibiotic resistant, like MRSA. So we see it getting spread around a lot and being resistant to treatment. And then the antibiotics we often have to reach for to treat MRSA can be dangerous to the patient as well. So that's the bigger issue. Vancomycin is often a common one we reach for to treat MRSA, and it can have, kidney damage associated with it. So it depends on the patient's health and stuff like that. Okay, moving on in this chapter, we have gas gangrene. And this is an infection that basically can affect deeper tissues. Now we're talking about not just progression in the skin, but now into the deeper tissues below that, in the dermis itself, and then into the fascia, and then into the musculature as well. And so this can lead to myonecrosis, which is necrosis of muscle as well. And this is driven by the bacterium Clostridium perfringens. So what do we know about this? What do we know about Clostridium perfringens based on its name alone? We know that if it's Clostridium, that it must be an endospore former. Endospores. We also know that it's gram-positive. Some other things about Clostridium bacteria to be aware of is that they're all anaerobic. They are strict anaerobes. They cannot even tolerate, they're not even aerotolerant. They can't even tolerate oxygen. And so they form endospores in the presence of oxygen. But whenever the endospores get deep into the tissues away from oxygen, then this can lead to development of gas gangrene. And so we often see these bacteria growing deep in the tissue, like in the muscle tissue, and then producing gas as a byproduct of their anaerobic respiration. So I'm not talking about fermentation, I'm talking about anaerobic, true anaerobic fermentation, or yeah, true anaerobic respiration. And they can make gases like H2S, which is technically a gas in its normal state. They can make H2S and hydrogen and stuff as a byproduct of their anaerobic respiration, and that can build up in the tissues. When gas builds up in muscle tissue, it will lead to, and the bacteria growing in the muscle tissue will have influx of fluid, will have buildup of gas inside of the muscle tissue, and that causes the tissue to swell to the point that it will rip open the tissue, including the skin that covers it. So oftentimes, one of the best treatments for this, when we start seeing that swelling, we will have to perform fasciotomies in order to relieve the pressure, to let the gas and the fluid escape so we're not ripping open the skin. And then once we treat the infection, we can close that skin surgically and hopefully reduce the likelihood of secondary infections and allow for proper healing with less scarring. So that's often a way that we will treat gas gangrene. Again, this is usually progressive spread of that infection underneath the skin once it is introduced into the deeper tissues. Clostridium perfringens is also associated with GI food poisoning, which we'll talk about in chapter 23 a little bit more. All right, and the next one for our review is chickenpox. Chickenpox is caused by a human herpes virus known as varicella zoster, or zoster, however you want to pronounce it. And it is a virus that lives in your nervous system, often in the peripheral nerves, and wherever it allows for the infection to hide out in your deeper nerves, it can reactivate along those nerves later on in life. So once you have had the chickenpox, the virus will hide out in your nervous system in a latent phase. And they can be reactivated whenever you're stressed out and your immune system goes weaker. And that is what we see shingles as. So shingles is just re-expression of a chickenpox illness that you had previously in life. And that's what shingles is. So it's the same virus that you had in your past, just reactivated. We often see it expressed usually in older folks, usually over the age of 50, which is when we recommend getting boosters to prevent shingles. Obviously, there is now a vaccine available for varicella zoster, so you can protect yourself from even getting it in the first place. If you've never had chickenpox ever, then you can't get shingles. Okay, so that's the idea is let's prevent you from getting it altogether, and you're better off that way. All right, next we have smallpox. Smallpox is a pox virus. Chickenpox, not a pox virus. Does it cause a similar outcome of illness where we get little, vesicular rash all over the body? Yes, but a pox virus is a specific kind of virus. It's not a herpes virus. It's called a pox virus. They're much larger viruses and they can code for many more genes. Smallpox is caused by variola virus. There are two different types of variola, variola major and variola minor. Most commonly, when we talk about smallpox infection, we talk about variola major. It caused a very disfiguring rash, and it has been around. It's one of the oldest diseases ever known in mankind, documented in like mummies from thousands and thousands of years ago, from like the fourth century and stuff like that. We have documentation of mummies that have presentation of illness that looks exactly like smallpox. So this is something that's been around pretty much since the beginning of mankind. But then Edward Jenner discovered that milkmaids were not getting smallpox. And that's why they used to have that saying of, pretty as a milkmaid or whatever, because milkmaids never got this disfiguring rash that left scars. And so people did notice that if you got smallpox at a younger age and you were able to recover from it in a controlled way, that you never got smallpox again. And he put that same thing to mind when he noticed that people who got cowpox didn't get smallpox. And cowpox was much less serious. And so he took the cowpox virus called vaccinia and then used it to inoculate a boy and then exposed that boy to smallpox and he didn't get it. And then that became the standard of practice over the course of time until eventually it became the widespread way of preventing smallpox. And then in 1977, we had the last case of smallpox. And then nobody ever got smallpox again after that. And then in 1980, they declared the world to be completely eradicated of smallpox. There was no more cases since 77, and we had such widespread protection from having had the vaccine spread to everybody that they actually stopped recommending the vaccine because it was unnecessary because there were no cases. We've had no human cases of smallpox since the 1970s, since 77 in the world. So it's been eradicated thanks to vaccination, a disease that existed on the planet for thousands of years that no longer exists naturally on this planet. And that's quite an achievement. Next was the measles. We have it in our skin and eye infection. It's, of course, spread through respiratory droplets. It is easily the most contagious disease that's ever existed on the planet, measles virus. It's caused by the measles virus, which is a morbillivirus. And it causes a rash, very characteristic rash. Um, it's a viral infection and obviously pretty common. It's not, how do I say this? It's uncommon to get meningitis or encephalitis from measles, but it's not super rare. So if you get the measles, smaller children are still at higher risk of having encephalitis or meningitis resulting from measles infection. And the more often you get repeat measles infections, the more likely you are to have encephalitis or meningitis. And the mortality rate of meningitis, encephalitis caused by measles is pretty high. It's pretty high. So it is something to look out for. 1 in 1,000 people that do end up with that would end up dying from it. So it's pretty high risk. It is one of the most effective vaccines and one of the safest vaccines that's ever been developed on the planet. So it is recommended to get vaccinated to prevent that disease. Um, Ringworm. Ringworm is what we call a cutaneous mycosis. So we'll write it out. Cutaneous mycosis. Whatever. This is a C. Well, it doesn't like me doing that. Let me try rewriting it. There we go. Okay, cutaneous mycosis. Cutaneous means on the skin, and mycosis means fungal infection. And it's cutaneous mycosis caused by dermatophytes, which is a select set of fungi that cause cutaneous mycoses. And so, fungal infection, we often name them as worms because when this first started, it caused like a rash on the skin that looked like a worm was underneath it with the way that it was swollen and red in a circle pattern. But it is not caused by worms, it is caused by fungi. Don't fall for the name. It is caused by fungi. What type of diseases fall into ringworm? I know we're used to seeing like the typical, body type of rash associated with ringworm and knowing and calling that ringworm. But other diseases that fall into the ringworm category, other diseases that we call cutaneous mycoses, would include athlete's foot, also known as tinea pedis. This is caused by dermatophytes in the feet. That's athlete's foot. It's still a type of ringworm. And we can have it associated with the scalp, Tinea capitis, or in the beard, Tinea barbae. Tinea corpus is anywhere else on the body. And so we have these different kinds of ringworm associated with different parts of the body. They are more likely to be caused by certain species of fungi, but all of those fungi are called dermatophytes, and the disease is still a cutaneous mycosis. Okay. Then we have conjunctivitis. This gets into our eye diseases. Conjunctivitis, here we have inflammation of the conjunctiva, which is the protective outer layer of the eye. When that gets inflamed, remember inflammation is itis. And so whenever we have inflammation of the conjunctiva, it could be caused by an allergic reaction. Even like physical scratching of the conjunctiva can cause conjunctivitis. Allergic reactions can cause it. In that case, you would have copious clear fluid, runny eyes, and even runny nose associated with that. Viral infections of the conjunctiva, you will still have clear exudate, but you often has redness of the eye in slightly different presentation there. Whereas bacterial conjunctivitis, you can call it pink eye if you wanted to, with that redness of the eye. Bacterial conjunctivitis, you'll have the pink eye, but you also have a milky discharge. So if it's pink eye with a clear discharge, it's viral. If it's pink eye with a milky or yellowish discharge, it's bacterial conjunctivitis. Anytime that there is infection or inflammation of the cornea, which is actually our outer like windshield of the eye itself, that would be called keratitis. And keratitis is often caused by, there's a lot of different things that can cause it. Herpes is a common cause of keratitis, as well as acanthamoeba, which is found in like water heaters and stuff, which is why we should not be using our contact lenses, washing them in tap water. Always use sterile saline for that. And then moving on to trachoma. Trachoma is an eye infection that is associated with chlamydia trachomatis. There are different serotypes of chlamydia trachomatis. The serotypes, the subspecies, if you will, of chlamydia trachomatis associated with trachoma are a different species than the ones that are associated with chlamydia, the sexual disease. But they are both chlamydia trachomatis, okay? Chlamydia trachomatis causing trachoma. This is the leading infectious cause of blindness worldwide. And so we often see this in underdeveloped countries, and it leads to inflammation of the eyelid to the point that the eyelid causes scarring of the cornea, and that's what causes the blindness. It is reversible, it is treatable with antibiotics. River blindness is blindness that is caused associated with having a helminth infection. So we have onchocerca volvulus. We also call this oncho H. Okay, cerciasis. My handwriting is terrible on this pad. So this is onchocerciasis, and it is a helminth infection. This kind of leads into what we're going to start seeing in chapter 23 when we get into our helminth infections a little bit more. This one's localized to the eye. So this is when a helminth gets inside of your eye. And so what often happens is that flies will land on eyes, and then they will deposit the larvae or the eggs associated with this. And then the larvae burrow into the tissue of the eye and then eventually make their way through the vasculature into the eye itself. And then they live as a worm inside of the eye cavity. Um, they themselves, the worms that are associated with this, the worms, the Onchocerca volvulus, they're infected with a bacteria called Wolbachia. So Wolbachia is the bacteria, Onchocerca volvulus is the worm. The worm being infected with Wolbachia is what makes the worm able to cause disease. And this we see this often in helminth infections. And so a lot of our helminth infections are basically the reason they can cause disease is because they're infected with Wolbachia. So a lot of times when we treat our helminth infections, we combine our helminth therapies, ivermectin, pyrantel, praziquantel, pyrantel, or ivermectin. We often pair it with doxycycline. Doxycycline is a antibiotic for bacteria, but we pair it because it kills off the Wolbachia bacteria and makes the worms far less pathogenic. It's just crazy to me, but it's true. And so we often have those paired together. Even when we're treating heartworm, the recommended therapy is to combine ivermectin with doxycycline, and that helps kill the bacteria that are helping drive that helminth causing disease. So pretty interesting stuff. That's it for chapter 19's summary. So we'll move on to chapter 20 and summarize that. The central nervous system, the peripheral nervous system. Obviously, the central nervous system is your brain and spine. Then peripheral nerves are anything branching off from that. We have protection of the brain and the spine by bony skeletal structure. Obviously, the brain is protected by the skull, the spine protected by the spinal column, your vertebrae. And the outer layer of your nervous system, we have a three-layer outer layer called the meninges, and it's the dura mater and the pia mater, and I can never remember the third one. Um, those three layers. I feel bad that I don't know. If you guys have taken anatomy, you probably remember what the third one is. Obviously, I'm not going to test you on the three layers of the meninges. But anyways, moving on, you do need to know the meninges is the protective outer layer of the nervous system, and it can become infected. And so, with that infection, that would be meningitis. If that outer protective layer gets inflamed from the infection, meningitis. Okay. That leads to specific types of presentation where we would see, sensitivity to light. We would have headache, we would have fever, and we would have stiffness of the neck. And we have something called Budzinski's sign, where like if you're laying down and we're bending the knees, it can cause somebody to reflexively bend the neck, for example, and vice versa. So the problem is when we have infection in the nervous system, our immune response and the inflammation that comes along with it can cause damage to the tissues nearby. And my brain is like floated away momentarily. The inflammation can cause damage to the tissues nearby where there is inflammation. This isn't a big issue if we can regrow tissue, but in the nervous system, especially the central nervous system, we can't regrow nervous tissue. Peripheral nerves are limited depending on what the nerve is. Basically, the bigger the nerve, the less likely we can repair it, typically. So we don't want to cause damage to the nervous system if we can help it. And so the nervous system is an immune privileged site. There's also no biota associated with the nervous system, no natural biome. It should be a completely sterile environment as far as a microbiome goes. So no natural bacteria or anything that normally inhabit that type of tissue. It's immune privileged, meaning that it is basically controlled by its own type of regulation of immune response. There are specific cells like microglia and stuff like that that are basically brain macrophages and stuff that are basically trained to have a less significant or severe inflammatory response and stuff like that, just to protect the tissues. But this also kind of leaves it a little bit open to infection. The other thing that controls passage of microbes or drugs or even the immune response into the central nervous system is the blood-brain barrier. And it quite literally, when we learned about how white blood cells can kind of travel across from the blood and into the tissues, and how they would squeeze between the cells of your like capillaries. Those junctions where we'd squeeze between through diapedesis, right? That junction would be tighter in the blood and between the blood and going into the brain. So the junctions going into brain tissue, into the central nervous system is tighter. And that's a literal barrier for the blood-brain barrier. So less things can travel across. This doesn't protect against everything. And oftentimes, the bacteria that are associated most commonly with meningitis, they have ways around it. Some of them actually live inside of cells and they can migrate through cells from cell to cell through the cells. Is a blood-brain barrier going to protect from that? Unfortunately not. But it could, inhibit our body's ability to respond to things. And then if the bacteria can cross, there's drugs that can't. And so it can limit our ability to treat infections that are in the brain and stuff like that. So there's pros and cons to the blood-brain barrier. There's pros and cons to immune privilege. And there's pros and cons to not having a biome associated with these areas as well. Back to meningitis. There are three groups of microbes that are commonly associated with meningitis. This is by far not a comprehensive list, but these are our most commonly associated causes of meningitis. Okay. You will have bacterial meningitis, fungal meningitis, and viral meningitis that we'll talk about in the chapter. Can you have meningitis associated with a protozoa infection? Absolutely. Okay, absolutely. But these are the more common ones. So we're just focusing on these three. Bacterial meningitis. The most common cause of bacterial meningitis is Streptococcus pneumoniae. You do need to know Streptococcus pneumoniae. Does it sound like it causes pneumonia? You're right, because it does. It's also the most common cause of pneumonia. Just happens to also be the most common cause of meningitis. So Streptococcus pneumoniae is also known as the pneumococcus. There is a pneumococcal vaccine available. We often recommend it for people that are older. So, and pretty much anybody over 30, we often recommend the pneumococcal vaccine, or people that are going to be more likely to be infected, maybe people who are in healthcare and stuff like that. So this is the pneumococcal bacteria. It is gram positive. As the name suggests, it's a streptococcus. So it often exists in chains or pairs. Gram positive pairs or chains, right? Okay. The next one is the next most common, and it's also the worst one you could get. And that is the meningococcal meningitis. It is caused by Neisseria meningitidis. All right. Oftentimes, meningitis caused by Neisseria meningitidis, oftentimes it is associated with a rash, which is kind of the characteristic of meningococcal meningitis. High mortality rate, somewhere around 30 to 50% mortality rate, whereas streptococcal pneumonia, the pneumococcus one, is usually about 20, between 10 to 30. It just depends on the patient, okay? But 30 to 50 with Neisseria meningitis. And this has got the rash. It's a petechial rash. What drives development of petechiae? Well, first of all, petechiae, this is whenever the capillaries under the skin burst and kind of rupture open, and it leaves these little like spider-like bursting. They look like spots at first glance, but it's actually caused by the capillaries bursting under the skin. And the petechiae in this case, it's caused by the toxin associated with lipopolysaccharide, okay, which is also known as endotoxin. And the effect of endotoxin being there is what's leading to that inflammation that is causing the petechiae. There's other toxins that are associated with this bacteria that can help with that process as well. Because Neisseria meningitidis, obviously, if it has LPS, this is a gram negative. It's also a diplococcus. So we can see here already, if I get somebody who I think has meningitis and I do a gram stain, we've got some information here. If we have meningitis and I do a gram stain, we might see cells that have a nucleus. If the pathogen has a nucleus, then it is a eukaryote, then it'll be fungal. If we don't see the pathogen at all, we call it aseptic meningitis. It's often viral. You can't see viruses on typical light microscopes. You're not going to see a virus on a gram stain. Okay. So if I look in your CSF, you're showing all of the signs and symptoms of meningitis, but I don't see anything in your CSF, maybe some white blood cells, maybe an immune response, but there's no pathogen. It's probably viral meningitis. We call it aseptic because there's no evidence of pathogen there. Doesn't mean there is pathogen, isn't pathogen. It just means we can't see the pathogen. All right, and if we see cells that have no nucleus, all right, if they are purple, they're gram positive. If they're purple and they're chains of circle-shaped cells, spheres, round cells, it's probably Streptococcus pneumoniae. If they are red, pairs of round cells, then there's probably Neisseria meningitidis. Then we have Haemophilus influenzae. This is gram negative, and it's a bacillus. Whereas Listeria monocytogenes is gram positive bacillus. Immediately, we can tell all four of these different bacterial meningitis apart just from the gram stain. And this information is part of the chapter. It is part of stuff that I do cover in the lecture. This is just me giving a little briefing on it. So we could do a gram stain of a CSF and then diagnose it as pneumococcal meningitis, meningococcal meningitis, or Haemophilus influenzae bacterial meningitis, or Listeria monocytogenes meningitis. It does help to have some preface of the patient's history if we have it, but if we don't, we can do this just with a gram stain. If it's viral meningitis, most cases of viral meningitis in otherwise healthy people you'll recover on your own without treatment. Okay? Most recover naturally. All right. Meningitis can also be caused by, we can sometimes see it caused by measles or by herpes as well. So, but the most common viral cause of meningitis will be enteroviruses. So viruses that get in from ingestion. And again, you're most likely to just like recover. So adenovirus, a kind of common one, for example. All right. So you don't need to name the viruses, but most commonly viral meningitis is associated with enteroviruses. Entero means gut. Okay, so they got in through ingestion. So fecal oral transmission, but then it migrates into the nervous system. Another virus that is fecal oral transmission that gets into the nervous system, which we'll talk more about in a moment, is polio. Fecal oral transmission of polio. We know that's a nervous system virus. So anyway, that's the viral one. Coming back to Haemophilus influenzae for our bacteria, again, gram-negative bacillus. There is a vaccine for it, usually given to more elderly folks. It's called the Hib because it's Haemophilus influenzae serotype B is the most common version that leads to meningitis. There are different serotypes. They can all lead to meningitis, but the most common one is the serotype B. What's a serotype, you ask? That means that we did immune testing on it, and based on it binding to this antibody, it is serotype B. If it bound to a different antibody, it would be serotype A or C or something else. Okay. All right, Listeria monocytogenes. This is one that is foodborne, and it's usually through undercooked meats that we see it transmitted, but it can be also present on other types of foods. This is why we tell pregnant women to microwave their lunch meats because Listeria can actually migrate in across the placenta as well as across the blood-brain barrier. So it's one of the few that can actually cross some of those barriers that are natural in our bodies. It can lead to stillbirth and stuff like that in pregnant women, so it is not a joke. It should be taken seriously. For otherwise healthy people, though, we usually don't see Listeria leading to serious illness. You might have a little bit of upset stomach or GI issues, maybe a bit of flu-like illness, but it's unlikely that it would cause illness in otherwise healthy people. If you're immunocompromised for any reason is whenever you're going to have a risk for meningitis or even association with illness during pregnancy. 30% chance of getting sick with that listeria during the pregnancy. So it's a pretty serious issue. We want to protect from that and make sure we're cooking our foods before we eat them. And all of those bacteria can cause meningitis, bacterial meningitis. Um, Obviously, again, I say the worst one is meningococcal. And if we suspect it's going to be one of these four, you come into a hospital and we'll start giving you broad spectrum antibiotics that could treat any of these four. And then we'll get your CSF sample after that while we're treating you and then narrow it down. And then we'll give you a more targeted therapy based on what your CSF gram stain shows. It's usually the gram stain is the key there, and it gives us enough information about the pathogen to know how to move on from there. Fungal meningitis is usually not transmissible from person to person. I say usually, I mean quite literally, like it's almost never been documented that fungal meningitis be transmitted from person to person. The most common cause of fungal meningitis is going to be Cryptococcus neoformans. It is found in bird droppings. It's pretty common in urban settings, but in the homeless populations that have HIV, typically resolving into AIDS. So if we have AIDS, if we have an immunodeficiency, then we're going to be more susceptible to contracting cryptococcal meningitis as a result of being exposed to bird droppings in the natural environment. Coccidioides immitis, it commonly causes something called valley fever. It's a fungus. Again, this is not usually going to be found in otherwise healthy people. It's a pretty rare illness, and we only see it in the Southwest. It hasn't really been found in other areas of the US commonly. And it usually causes valley fever, which is a different kind of a disease, have a little bit respiratory, a little bit flu-like illness, and it rarely causes meningitis. And it's not commonly associated with meningitis, but it's probably the next more common one next to cryptococcal neoformans types of infections. And we already covered the viral meningitis. So next is meningoencephalitis, which is our in-between one. Most significant cause of meningoencephalitis. Anything that can cause meningitis and encephalitis could cause both meningitis and encephalitis at the same time. And that's what meningoencephalitis is. But some significant ones that are more commonly associated with specifically meningoencephalitis. So, what is encephalitis? Infection of the brain. Again, meninges, infection and inflammation of the covering of the brain. So, when you got both, it's meningoencephalitis. And a common cause of meningoencephalitis, not common, I shouldn't say it that way. An important cause of meningoencephalitis is the brain-eating amoeba. So, we've heard of it called that, but there are two species of amoeba that can cause meningoencephalitis. And they're both very rare, but they're both about 97% mortality. So very high mortality. And oftentimes that other 3%, 2 to 3% that survive it will have mental deficits, almost always. So it's not something you just recover from easily. And most of the treatments that are available for meningoencephalitis aren't fast enough to effectively treat it. And so that's the other side of it. Commonly caused by Naegleria fowleri or acanthamoeba. Both of them are amoebas. Naegleria fowleri is associated with PAM, which is primary amoebic meningoencephalitis. Acanthamoeba causes GAM, which is granulomatous amoebic meningoencephalitis. The PAM one, we'll just say that. The primary one. It is usually more acute and faster to occur, and GAM is a little slower to occur, and it's not chronic, but it's just less acute. But both of them are just as deadly. And Naegleria fowleri and acanthamoeba are contracted usually in different ways. So Naegleria fowleri is often just from warm, freshwater types of water, bodies of water, like swimming in a pond or a lake that has this amoeba in it naturally, and often gets forced into the sinus cavity and then can cross over into the blood-brain barrier. Again, it's extremely rare. We do not have a lot of common cases of this. Whereas acanthamoeba can often be introduced through the eye, usually again through contact use, but still pretty rare. Doesn't usually cross into the brain. It's more likely to cause keratitis. But if you get keratitis from this and you leave it untreated, that's a pretty quick transport into the brain. So that's where we could see GAM developing. So be aware of that. For encephalitis, again, encephalitis is infection leading to inflammation in the brain. For infectious causes of encephalitis, the most common by far are going to be, well, herpes for sure. I'm just saying. Herpes is the most common cause in the world of encephalitis. But after that, we have the arboviruses. And the arboviruses, anytime you hear arbovirus, it is a virus, obviously, that is transmitted by a biting insect. Most commonly mosquitoes, but if it's transmitted by tick or something, it's also still arbovirus. So mosquitoes, biting flies like midges or tsetse flies, those are viruses that are transmitted by biting insects are called arboviruses. And so with acute encephalitis caused by arboviruses, this is a fancy way. It's what we're talking about when we talk about West Nile virus, Zika, Japanese encephalitis, Eastern equine encephalitis, Venezuelan encephalitis, stuff like that. So some of those can cause extremely severe disease. A lot of them, like West Nile virus. We estimate that most people that live in areas with mosquitoes have probably contracted the virus in their life, including you and me, but probably cleared it with almost no symptoms. A small percentage of people that get these viruses could develop encephalitis. And the encephalitis can be deadly, but you can recover from it too. And so it's pretty rare that it's going to cause death. It's still pretty uncommon that it's even going to cause any disease. More commonly, you're going to have very, very mild disease if you have any symptoms at all. So only about 20% of people that get the infection will have any symptoms at all. And this is based on people getting tested and reporting being positive. How many people aren't getting tested for it and aren't being reported? So we think that the number is actually higher for infection without signs or symptoms for West Nile virus. Some of these other ones you're more likely to have. So it just depends on the virus. But anything transmitted by a bite, any virus transmitted by a biting insect is known as an arbovirus. Moving on to other causes of encephalitis, acute encephalitis can be caused by rabies. In fact, that is the primary presentation of rabies. You're really only going to see it expressed as encephalitis. Rabies is caused by the rabies virus. It's known as a type of virus called a rhabdovirus. And it is, an enveloped, bullet-shaped virus. And basically, it's transmitted through the saliva of infected mammals. And then it starts out when you get bitten by a rabid animal. The virus is in the saliva. It gets introduced into the tissue first through the bite. It can't get in through intact skin. So you have to have broken skin exposed to saliva, but it doesn't require much of a break in the skin in order to introduce that saliva. Any break in the skin plus saliva will almost always lead to rabies. So if you have a rabid animal, if you have an animal that bites a person, just assume rabies. Assume it. That is a safe bet because once that virus migrates into the nervous system and we start having signs and symptoms, then there's nothing we can do for you, literally. So between that, though, if you get bitten by a rabid animal, between the time of the bite to the time when you have signs or symptoms is usually about a month or two. And so you wouldn't know until a month or two later. Then suddenly you have flu-like symptoms that quickly progress into neurological, first in your periphery, and then it progresses into hypersalivation. And then eventually you can't swallow anymore. And then that leads to what we call hydrophobia. It is not an actual fear of water. It's an inability to swallow anything. And because you can't swallow, then people start panic, or the animal will panic because they can't swallow anything. And so it looks like fear of water, but it's more or less like a severe panic attack associated with swallowing. And they can't swallow anymore. And that's why we get foaming at the mouth, where the virus will be expressed in the saliva. You can't swallow the saliva. It builds up as foam in the mouth, and then you bite the next victim, and that's how it's transmitted on after that. So that's rabies. Isn't it fun and exciting? It's 100% fatal once we start having signs and symptoms. There is nothing to do with it. But in that time in between the bite and our first signs and symptoms, we can introduce some therapies that can prevent the signs and symptoms from showing. But we have to know we need to treat. And so treatment for rabies is usually going to be introduction of the vaccine, which we know is available, as well as simultaneously infusion with antibodies from serum from people that have had rabies. And so we call this post-exposure prophylaxis. Um, and so it's basically like it will infuse you with the immunoglobulin for antibodies that will protect against the virus from, attaching to your nervous system cells. And usually the window for this is about a week to 10 days. And if you miss that window, then oftentimes, if was, rabies virus, then, we will miss that window. So it's a pretty quick one. So if you know anybody that gets bitten by an animal and you're not sure, just go ahead and go to the hospital and be honest about that. And they will almost assuredly start at least the shots for the vaccine for it, depending on your exposure and your risk and stuff like that. Next is poliovirus. This is one of the smallest viruses that infect people. It's a picornavirus. It is a naked virus, no envelope on this one. And it is a super, super tiny virus that is an enterovirus. So it does get in through the gut, you ingest it, and then it migrates from the gut into the spine and into the nervous system. Often affects the periphery or directly the nervous system, and can even affect your brain and your function, ability to control muscle function overall. We see this leading to people that were in iron lungs that could no longer even breathe for themselves due to the paralysis associated with this type of viral infection. It only exists in the human population. There are no animals that get poliovirus. It is strictly a human virus. So, vaccination has been very successful in mostly eliminating it from the world, but we do still see infection present in towns in Afghanistan and in Pakistan, where it's just not as widely accepted to be vaccinated, and where the vaccination efforts are a little bit resisted, as well as getting to some of the rural areas. It's just been hard to get out to those areas and lead to vaccination. So we do still see poliovirus in the world. It's not here in the US, and it's really the only area where you have risk of that is in rural areas of Afghanistan and Pakistan. Then we have the prion diseases. The prion diseases are caused by misfolded proteins that then basically congeal and stick together in the brain and lead to holes in the brain. So that's what we were talking about throughout this semester, talking about spongiform encephalopathy. Spongiform means holes. It looks like a sponge, lots of holes. It makes the brain tissue look like a sponge. So spongiform, formed like a sponge. Encephalo means brain, pathy means disease. So brain disease that looks like a sponge. Okay. And it's from buildup from infectious proteinaceous particles, proteins that can cause other proteins to misfold like them. They do not have a genome, no genome. They are literally just misfolded normal proteins that just folded wrong. And then they come into contact with your actual normal proteins that have a normal function in your body, and they cause them to misfold. They no longer can do their normal function, and they just stick together, and they form these like plaques, sort of, and then lead to holes forming in the brain as a result of that. Oftentimes, exposure to prion, from the time of exposure to the prion to the time of disease, is multiple decades. So you can be exposed and not have any signs or symptoms for 30 years. And that's not uncommon. So anywhere from 10, as long as like 50 years later, you might not have any signs or symptoms. Typically, once signs and symptoms appear, it usually leads to death within a year or two. There is no treatment for prion diseases, but they are very rare. The few diseases that you should be aware of that are prion diseases are Creutzfeldt-Jakob disease, or CJD, which is the human version of the prion disease. That's just like you can have it genetically. If you get it from another animal, but it's the same misfolded protein, then that would be called variant CJD, VCJD, which is what mad cow disease is in people. In cows, it's mad cow disease. Once mad cow disease gets spread to people, it's VCJD, variant CJD. If people get prion disease from eating other people, as is performed in certain tribes in New Guinea, to venerate their dead, to make their dead family member one of them and incorporate them in their body and their soul in their body. They would eat their dead loved ones. If the dead loved one had a prion disease and you got that prion disease from eating the dead loved one, that was kuru. Kuru. In sheep, it's called scrapie. And in deer, it's called chronic wasting disease. And there are other versions of these diseases. Another one in people for a different protein that's also hereditary, it's genetically linked, is fatal familial insomnia, where a protein gets misfolded because of genetics of how that protein, it will just start one day to misfold. And then once it misfolds, it causes other ones to compoundingly misfold. And it leads to misfolding of a protein that's associated with sleep regulation. And eventually, those people can't sleep anymore and they die of a lack of sleep. The problem with prions is that they're from misfolded proteins, and the misfolded proteins can't be autoclaved to get rid of them. It's not hot enough to actually completely denature those proteins. They're so hardy with how they're misfolded that we have to use higher than 121 degrees Celsius. We usually have to do at least 134 degrees Celsius, which is very uncommon. We do not do that regularly. And we also often have to treat with sodium hydroxide. So you learned that's a powerful base when you took chemistry. So treating with a base, which will ruin our hydrogen bonds, and autoclaving it at 134 degrees Celsius. This is not a common practice, and so we usually only institute this type of cleaning instruments or reusable things if we know that this is going to be a threat. Next we have tetanus and botulism. I kind of pair them together because they're both caused by Clostridium bacteria. We learned about Clostridium causing disease in our skin and eye in chapter 20 with Clostridium perfringens. Now these are Clostridium tetani and Clostridium botulinum. Obviously Clostridium, we know immediately from the name. If it's Clostridium, we have endospores and we are gram positive. And we learned also from chapter 19 that they are true, strict anaerobes. You're fine. You go do what you do. And I'll keep recording, so no worries. All right, so these are endospore formers. They are strict anaerobes. So what's the deal with them? They form endospores. The endospores are found in the soil naturally. And these guys will like get introduced into the skin and or like through a puncture wound, or they could be incorporated into your canned food or into your beer or whatever. And then they will come back to life and start multiplying and then making their toxin. With tetanus, Clostridium tetani makes the tetanospasmin toxin. And what tetanospasmin does is it causes spastic paralysis. And that means once you flex a muscle, it stays flexed. It can't relax. So it's paralysis because we can't keep moving, but it's spastic because we're stuck having moved. You can't relax. So spastic paralysis means you can't relax. Flaccid paralysis means you can't contract. And botulinum toxin causes flaccid paralysis. Both of these will lead to death from suffocation eventually. So you either your diaphragm gets stuck contracted or it gets stuck relaxed. And either way you suffocate. So they can both lead to death that way. Death from these diseases is pretty uncommon nowadays because we have antitoxins and things like that that can counteract the toxin. There's antitoxins, there's other things associated with, muscle function that can kind of counteract the action of the toxins. But still untreated, this can be very, very severe disease, especially if it's not treated within a timely fashion. All right, moving on to the questions from each of these chapters. We'll start with chapter 19, our skin and eye diseases. First, we have impetigo. Often, again, this is an exfoliative, peely, flaky sort of skin disease. And it is typically associated with Streptococcus pyogenes. Sorry, trying to reorganize this. Okay, it's often most commonly associated with Streptococcus pyogenes first, and then the infection progresses for Staphylococcus aureus. And the Staphylococcus aureus almost always outcompetes strep. These guys have very specific, unique kind of virulence factors associated with them that we have to be aware of. They have exfoliative toxins that cause the flakiness. The exfoliative toxins of staph are much more significant than for strep, and that's why usually when we start seeing that flaking, it's mostly usually caused by staph at that point. But it starts with strep, then staph takes over, and the exfoliative toxins made by staph are what are going to cause that blistering or that flakiness associated with impetigo. Staph also produces coagulase, which is an enzyme that coagulates plasma and blood and is often used as a diagnostic test for staph, which is talked about a little bit more further in the lecture. So let's talk a little bit about, let's give some examples of questions related to this topic. That's what I'm trying to say. So, which organism is associated as one of the causes of the disease impetigo? Streptococcus pyogenes. Yes, it's usually the first one. What about Staphylococcus epidermidis? This is the common bacteria found on the skin. Most people, this is just a part of your microbiome. It's not usually associated with infection unless it gets into your deep tissue accidentally for some reason. So it's not typically associated with impetigo, though. Streptococcus saprophyticus. Again, this is a pretty common microbiome organism. Whoops, common microbiome organism here, not typically associated with impetigo. Staphylococcus empiricus, not one that we have to learn about at all. Don't need to be aware of it at all. So, Streptococcus pyogenes. What was the other one that was associated with impetigo? Staphylococcus aureus. Both of them are gram-positive cocci. Strepto is the chain, Staphylo is the clusters. Next question. A culture grown from a 5-year-old's skin sample shows that it has visible irregular clusters of cocci. Is this consistent with a typical case of impetigo? Remember, if impetigo can be caused by Staph aureus or Strep pyogenes, irregular clusters does align with staph, right? So, yes, it matches the description of both typical causes of impetigo. No, it matches only the staph because strep is chains. So it's not this one, it's not both. Yes, it matches the description of one of the typical causes, probably this one. Let's look at our other choices. No, the typical cause of impetigo does not match. It does. It matches the Staphylococcus aureus, or there's no way to tell. We can, from the name, we can infer it. Just from the name, we know irregular clusters and cocci from Staphylococcus aureus. We should also know, because it's taught in the lecture, that these are both gram-positive organisms, and it's something else you would need to know. So what color would they stain with the gram stain? Purple. All right, next for chapter 19 are our cutaneous mycoses. Ringworm, not caused by worms, caused by fungi called dermatophytes. The disease is a cutaneous mycosis, that's singular. Mycoses are diseases. Tinea capitis, ringworm of the scalp. Tinea barbae, ringworm of the beard. Tinea corporis, ringworm on the body. Tinea cruris is the groin, so this is often jock itch. Tinea pedis and athlete's foot. Remember, pedis is foot. Tinea unguium. This is usually the nails. So nail fungus is what that's talking about. And these are all different types of ringworm, scientifically called cutaneous mycoses, and they're associated with dermatophytes. There are a lot of different microbes that are considered dermatophytes. They come often in these genera like trichophyton, microsporum, or epidermophyton. I'm not going to test you on those genera, but that's just examples, okay? But they are all dermatophytes. Lots of different species there, though. Okay, so here are some questions about the ringworm. Which type of microbe is associated with the skin disease ringworm? It is not a worm. It's not a helminth. It's not a protozoa. It's a fungal infection. And remember that scientific term is cutaneous mycosis. It's not bacterial. It's not protozoa. It's not a worm, a helminth. It is a fungal infection. A patient is diagnosed as having Tinea pedis, also known as athlete's foot, which is a type of ringworm. Well, thank you. Which of the medications below would be an appropriate treatment for this infection? So if we're looking for the cause of ringworm, remember this is a fungal infection. So we are looking for a drug that is an antifungal. This type of question is common on the final. Because here, did I tell you what type of drugs we would treat ringworm with in the lecture? Well, if you've watched the lecture, then you would tell me, no, you didn't. But did we talk about the types of drugs we use to treat fungal infections back in chapter 12? Yes, we did. So this would be pairing chapter 12 with chapter 20. Common type of question on my final exam. So which of these examples would be a drug that we commonly use to treat fungal infections? And I even give you an info. On my exam, I'm not going to give you this, right? So miconazole, that azole means it is an antifungal. Now you might be looking ahead at D and say, well, metronidazole is an azole. We rarely use metronidazole to treat fungal infections. Could we? Does it sometimes used for fungal infections? Yes, but it's most commonly used to treat protozoa and anaerobic bacterial infections. So not usually used for fungi. Ivermectin is for helminths, so parasitic worms. Penicillin is an antibiotic, so it's for bacteria. Miconazole is an antifungal. It's an azole. It's not the one that went to the big metro and graduated up for amoebas and anaerobic bacteria. Miconazole is the correct answer here. Another example would be ketoconazole, fluconazole, and the one other major antifungal we needed to know from chapter 12 was amphotericin B. It's not an azole. All right, so let's get into chapter 20. Cryptococcal meningitis, fungal meningitis. So, Cryptococcus neoformans is the most common cause of fungal meningitis, but it's usually associated with AIDS. And then our second one that we talked about in chapter 20 was Coccidioides immitis. Also can cause meningitis. It's less commonly seen to do that. It's usually found in the southwest of the United States, like in Arizona, the southernmost parts of California, areas like that. Both of these are associated with inhaling the spores. Cryptococcus neoformans is the spores are typically found in bird droppings, whereas Coccidioides immitis, the spores are found in the environment, just naturally. All right, so if our fungal, okay, let's just start with questions. Let's not get ahead of myself. Which of the following is a causative agent of fungal meningitis? There are only two we learned in the chapter. Cryptococcus neoformans or Coccidioides immitis. But what were our choices here? Clostridium perfringens. This is the cause of gas gangrene. This is another very typical type of question that I'll ask for like unit 4 type stuff on the exam. All right, Clostridium perfringens causes gas gangrene. Cyclospora, we will learn in chapter 23, is a cause of diarrhea, and it is a protozoa. Coccidioides immitis, this is a fungal meningitis. Crimean Congo HFV, this stands for hemorrhagic fever virus. It's a virus, it couldn't be a cause of fungal meningitis. So C is our answer here. And then next, which form of fungal meningitis is usually associated with AIDS? And that we just have to know. Remember, Cyclospora, this is a protozoal diarrhea. Cryptococcus neoformans found in bird droppings, often associated with AIDS patients, fungal meningitis. Coccidioides immitis, it does lead to fungal meningitis, but it's not associated with AIDS. It's just one of those random types of illnesses. And then Clostridium perfringens associated with gas gangrene. That would not mean. So B is our best answer here. All right. Next are our meningoencephalitis. The two major forms that we talked about, the two major pathogens that we talked about that could cause meningoencephalitis are our PAM and GAM, primary and granulomatous. What does primary mean? More acute, it's going to be faster, and it is associated with Naegleria fowleri. PAM. Acanthamoeba, both of these are amoebas. What are amoebas? It's a protozoa. Single cell eukaryotes. Okay. So, granuloma means that we would wall the infection off with white blood cells. So whenever we're walling an infection off with white blood cells, it forms a structure that we call a granuloma, right? So If we have that happening associated with meningoencephalitis, infection and inflammation of the lining, as well as the structure of the brain, that's granulomatous meningoencephalitis. And it's amoebic because they're both caused by amoebas. Okay, there's more information on that slide if you would like to review it on your own time. But for now, we only have two types of meningoencephalitis we really focus on in chapter 20, PAM and GAM. PAM is associated with Naegleria fowleri. GAM is associated with acanthamoeba. So I'm going to write that down. So for our reference, all right. So which of the following pathogens is an amoeba? This is another type of question I might ask you. You need to know what these pathogens are. What type of pathogen are they? You need to know that Naegleria fowleri, if I just say, hey, what is Naegleria fowleri? You should tell me it's an amoeba if we've talked about it. So what is Neisseria gonorrhoeae? Well, we talked about Neisseria meningococcus. All Neisseria that we're going to learn about in our class. We have Neisseria gonorrhoeae, the cause of gonorrhea, and Neisseria meningococcus, the cause of meningococcal meningitis. These are bacteria, and you do need to know that because we talk about it in the chapters, okay, in Unit 4. Alcaligenes faecalis. We didn't learn about this in Unit 4, so I wouldn't expect you to know this one, but we saw this one in our lab. If you sat at table 1, your gram negative was this. So this is a bacteria also. Wouldn't need to know this for the class, but I could have just as easily have put Escherichia coli, which you would need to know is a bacteria. Naegleria fowleri, amoeba, which is a type of protozoa. Erythema infectiosum. This isn't really so much a name of an organism as much as this type of disease or how it presents. This is usually associated with fifth disease, which is a skin infection caused by a virus. Not this, not this, not this. This one. Fifth disease is discussed in chapter 19, just FYI. All right, which of the following pathogens is the cause of PAM, primary amoebic meningoencephalitis? Acanthamoeba is GAM. Giardia lamblia is a type of chronic diarrhea. We'll learn about it in chapter 23. And Trypanosoma cruzi, or T. cruzi, or cruzii. This is going to be the cause of Chagas disease. Again, if you're wanting to learn about these, you're supposed to, FYI. We'll talk about Giardia lamblia and the diarrhea that it causes in chapter 23. We'll talk about Chagas disease and the illness that it's associated with. I believe that's in chapter 21. That's in the cardiovascular. I'm pretty sure that's in that chapter. Naegleria fowleri, this is our cause of PAM. It's amoeba, a protozoa. That's that one. All right. So even though this was pretty easy approach, these types of questions are common on the Unit 4, and you won't always be given context. It'll just be like, which one of these is an amoeba? Which one of these is a protozoa? Which one of these causes this disease? This pathogen, which disease does it cause? That sort of stuff is pretty common when associated with Unit 4. Some of them, again, crossing units or crossing chapters with some of the questions, pretty common in Unit 4. All right, so that's it for our review for chapters 19 and 20. I hope this was helpful for you guys. Happy studying whenever you guys get to it for the final exam. And let me know if you have any questions, email me, and good luck on the exams.